Welcome to another EduMed video, and today we'll be going through the next part of the beginner's guide to intensive care therapy and talking about the basics of ventilation. Now, in this presentation, we'll talk a little bit about why we need to ventilate patients, and then think about the two core points of ventilation, which is oxygenation and carbon dioxide removal. This is a really important lecture, and before you go on to any future presentations that I will give on ventilation, I think it's really important to listen to this one, as this will give you the fundamental basics of what you need to do when managing a patient who is in respiratory failure. So the first question is, why do you need to ventilate? And I think it's always worth asking this question because sometimes we look at intubation and ventilation as just the next part of the algorithm of treatments for a patient. For example, the asthmatic patient who comes in who's deteriorating, the immediate thought is, we need to intubate and ventilate this patient. Now, as you will see in later videos, intubation, ventilation and positive pressure ventilation specifically in patients with asthma may not always be the right choice. And actually you need to think about the mechanics of what is happening. And that is what we will be talking about a little bit in the lectures in the next set. So why do we need to ventilate? The most obvious thing is respiratory failure. That's what we think of when we think of the intubated and ventilated patient on intensive care. Usually the patient has some respiratory infection, be that a ventilator-associated pneumonia, or before that if they've developed any sort of asthma, COPD with an infective exacerbation, or just a simple pneumonia. And we talk about type 1 respiratory failure, where the patient's able to get rid of the carbon dioxide, so their CO2 may be normal or low, but they have a primary problem with oxygenation, and so they are hypoxic despite supplemental oxygen therapy. An important facet of intubation ventilation is to protect the airway. Again, please have a look at the videos that I did on the endotracheal tube and on the tracheostomy. Protection of the airway simply means that we have some way of preventing secretions, fluids from the oropharynx dropping down into the lungs through the trachea. And so for that you need a cuffed endotracheal tube, and in order for patients to tolerate an oral endotracheal tube, they need to be mechanically ventilated and sedated. Control of blood gases is a really important point. It sort of goes back to the point about type 1 and type 2 respiratory failure. If you have a patient who's hypoxic or hypoxic and hypercapnic, you might need to ventilate them to try and improve that. But actually it's a little bit more nuanced than that as well. Sometimes in patients who have severe metabolic derangements with a severe metabolic acidosis, patients can be breathing very quickly with a very high respiratory rate and therefore a high minute volume, and therefore trying to blow off as much CO2 to maintain a normal CO2 and therefore, a normal pH. And by taking over the ventilation, it might be important because if a patient's starting to tire, because they've been breathing so quickly at a rate of 40, 50 breaths per minute for an hour or 2 hours, they may start to get tired, and therefore their CO2 starts to creep up, and when they're that tired, the acidosis gets even worse, and they get a mixed metabolic and respiratory acidosis, which can make the situation even worse for them. So sometimes we intubate and ventilate patients just to get control of the patient physiologically. And the important thing also is when you sedate someone and take over their ventilation, the basal metabolic rate drops because they're not using their muscles as much, and they're sedated, and therefore their body functions just start to slow down. And all of these things can be important if you've got a patient who is hypermetabolic with sepsis, where actually giving them a period of quiescence may allow the antibiotics to work and therefore for the patient to get better. And going along with all of that, the tiring patient. any patient who looks like they're starting to tire with respiratory failure, you should think early about intubating and ventilating. Not only because the intubation and ventilation will allow them time to rest, but also often a tired patient starts to lose their pharyngeal reflexes, and therefore their risk of aspiration actually increases. So always be wary of the tiring patient. So with that in mind, we need to ask ourselves, what is the aim of ventilation? And it's simply three things. The first is protection of the airway, and we went through that in a lot of detail with both the endotracheal tube video and with the tracheostomy tube video, so I'm not going to go into that in any detail in this presentation. What I will go through is the second two components. That is to control the carbon dioxide levels and the oxygen levels in the patient. And that is all we really care about with ventilation. For all the fancy names and all the fancy modes and all the fancy knobs that are on a ventilator, the only two parameters that we actually care about for the patient are to control the oxygen levels and to control the carbon dioxide levels. Now yes, we will talk a little bit about lung protection in later videos, and we'll talk a little bit about protective lung strategies. However, when it comes down to it, the thing that will kill a patient is hypoxia, so we need to make sure we're adequately oxygenating a patient, and the thing that will make sure that the patient develops normal metabolism and metabolic function is a normal acid base and therefore control of the CO2. That's it. So for the rest of this talk, what I'll be thinking about is how do we manipulate the oxygen levels and how do we manipulate the carbon dioxide levels in the patient's body using a ventilator. And so in order to understand how to use the ventilator appropriately, you really need to have an understanding of how oxygen and carbon dioxide moves in the lungs, which is the primary area of carbon dioxide and oxygen absorption and excretion. And so in order to understand that, you need to look at this picture. This is the most important picture to have in your mind at all times when you're thinking about a patient who's on a ventilator. This is the alveolus, and into the alveolus comes gas that the patient breathes in and breathes out. When the patient breathes in, the alveolus fills up with an oxygen-rich mixture, and then that oxygen diffuses across a very small group of cell walls, two cell walls, to get into the capillary. And then the deoxygenated blood that comes from the right side of the heart flows through the pulmonary vasculature and then goes off being oxygenated into the left atrium. Similarly, when the deoxygenated blood comes from the right ventricle, it is full of carbon dioxide. That carbon dioxide then diffuses passively into the alveolus and then gets breathed out. This is all it is. This is all that happens in the lungs. Now, a question that sometimes gets asked is, when do you get oxygenation? When do you get carbon dioxide removal? And when we consider the oxygenation, if you ask a child, they'll say, when you breathe in oxygen, and then the oxygen comes, and then when you breathe out, the carbon dioxide comes out. But the reality is, as long as this alveolus stays open, oxygen will flow from an area of high concentration, i.e. in the alveolus, into an area of low concentration, i.e. into deoxygenated blood. So as long as that alveolus stays open, you will continuously get oxygen moving down the concentration gradient, which will usually be high in the alveolus and low in the alveolar arterioles and capillaries. Similarly, carbon dioxide will continuously passively diffuse from the blood vessels into the alveolus and then hopefully out. So it's not a matter of oxygenation happening during inspiration and expiration being the removal of the carbon dioxide. It is continuously happening. And that is the first and most important thing to recognize. So, what does oxygenation depend upon? The first and most simple thing is the amount of oxygen that you breathe in. The higher the amount of oxygen concentration in the alveolus, the more oxygen will diffuse across, the faster it will diffuse across into the pulmonary capillaries, thus oxygenating the blood. And so that's the first thing that you manipulate, and you know intuitively that's the right thing, because when you have a hypoxic patient, what's the first thing you do? You put some oxygen on them. All you're doing is you're increasing the concentration of oxygen inside the alveolus. Now, the second thing that it depends upon is that alveolus actually being open. If that alveolus is completely collapsed down, there's no gas in it, and therefore, even if there's blood rushing past it, there's no way for it to gain oxygen or to get rid of carbon dioxide because there's nothing in it. So, we need some way of keeping that alveolus open. You know that when you take a deep breath in, your lungs expand out, so you're opening up a lot of alveoli. Then when you take a deep breath out, what you're doing is you're actually collapsing some of those alveoli in the bases. So another way of trying to improve oxygenation is simply by trying to keep those alveoli open all of the time. And so the way in which you try to keep those alveoli open all the time is by using some additional pressure. So you will hear people talking about positive end expiratory pressure, PEEP, or continuous positive airway pressure. What this is during expiration, you're still pushing air in, you're still causing the pressure to stay high in the lungs, so it's not going to become negative, and therefore the alveoli aren't going to collapse, and by staying open, you're continuously allowing oxygen to diffuse through, both through the inspiration phase and the expiration phase of the patient. Also, if you've got sputum in there, if you've got anything blocking off the alveolus that's allowing it to collapse, if you suction it out, if you wash out the lungs, get rid of that sputum, then you're suddenly going to allow those alveoli to start getting gas into them, and therefore with the blood rushing past, you'll be able to get more oxygen to diffuse across into the pulmonary capillaries. Now, the other aspect of the oxygen diffusion is making sure that the interface between the alveolus and the pulmonary capillary is as short as possible. What can happen is if you've got infection, that the alveolus can become full of pus, or it can get inflamed, or the capillaries, if you've got a vasculitis, may become thick-walled and inflamed. And all of these things can make there be more resistance to the oxygen diffusing across into the capillary. So, this is where one of the fundamental aspects of respiratory care for intensive care patient comes in. What you want to try and do is reduce the amount of edema in this alveolar capillary interface. So this is why for any patient with respiratory failure, we always try to keep them relatively negative fluid balance. The reason being we want to try and improve that diffusion gradient, and we want to try and reduce the resistance of oxygen moving from the alveolus into the capillary. And so by improving that interface, we improve oxygenation. So that's thinking about the alveolus itself, but the other key component of this picture is the capillary itself, so the blood flow. There's no point in having an alveolus full of 100% oxygen if there's no blood flow going through it. And so we need to think about methods of improving the right side of the heart, so improving cardiac output. And this can be through using things like inotropes and by causing vasodilation of the capillaries. Now you can do that either by using systemic drugs. Things like milrinone are both an inodilator, and so it'll help to cause contractions in the right side of the heart, improve the cardiac output into the pulmonary arteries, but it can also cause some degree of pulmonary arterial vasodilation and therefore decrease pulmonary vascular resistance and therefore improve blood flow through the different aspects of the alveoli, and therefore improve the oxygen being drawn into the capillaries and the carbon dioxide being removed. Another important part is to try and improve the blood pressure. So in addition to cardiac output, you might need a certain level of blood pressure to overcome the pulmonary resistance that is inherent in the lungs. And of course, in positive pressure ventilation, you've now put a whole load of increased pressure into the thorax. That means all the capillaries are going to be squeezed that little bit more, and therefore pulmonary vascular resistance might be increased. And so using a combination of a vasopressor and an inotrope might actually improve pulmonary perfusion. And again, you know that inherently, if you have a very hypotensive patient, you see that the sats start to drop a little bit. And then the moment you give them a medication to bring that blood pressure up, suddenly the sats start to come up again. So always think about blood flow. And then there is the final concept of ventilation and perfusion matching. So what you want to try and do is to dilate the blood vessels that are coming near the alveoli that are full of gas. And you want them to not go anywhere near the bits of lung that are collapsed down and aren't taking part in gas exchange. The body itself has a way of doing this. Is so-called hypoxic vasoconstriction, where if the pulmonary vasculature is in an area where there is not a lot of oxygen, they start to vasoconstrict to prevent blood from going into those areas, and so shunting it to the areas that do have gas, air, oxygen available to them. There is a way to try and improve that even more. So you can use certain inhaled vasodilators. So nitric oxide is the commonly used one, but you can also use a prostaglandin like Flolan. And what they do is they get entrained into the oxygen that the patient gets ventilated with. It then fills up the alveolus, which has got the oxygen-rich gas in it. And because it's a vasodilator, it'll dilate up the vessel that's feeding that alveolus, and therefore improving the blood flow through that part. The great thing about this is that the bits of lung that aren't ventilated because there's collapse, consolidation, or just lots of pus in there, they're not going to get that vasodilatory gas coming into them, and therefore those bits of vasculature are going to remain relatively vasoconstricted. So by doing this, what you can do is actually improve ventilation perfusion matching, and you'll hear lots of people talking about this. Now this is a really important slide because this actually gives you all the things that you can do to improve oxygenation. The only things that you can do is increase the fractional inspired concentration of oxygen, which is something you would do intuitively by putting a gas mask on, say for example a 15-litre non-rebreathe mask. Making sure the alveoli are open all the time. And I say it again, gaseous diffusion is stupid. It doesn't care whether you're in inspiration or expiration. All it cares about is the concentration gradient. So if you have a high fractional inspired concentration of oxygen in the alveolus, if you keep that alveolus open for 100% of the respiratory cycle, you are continuously going to get oxygen diffusing into the blood. If you've only got that alveolus open for 50% of the time, then you're only going to get oxygen diffusion for 50% of the time. And therefore, you're halving the amount of oxygen that you're actually getting into the blood. Everyone always thinks about the lungs and about oxygen going in, carbon dioxide coming out. But the thing that people often forget about is perfusion to the lungs. Alveolar blood flow is so important. And so you must make sure you optimize the right and the left side of the heart and ensure that you've got a really good cardiac output that's bringing blood into the lungs, and you've got it at an adequate pressure head to overcome the pulmonary vascular resistance that's there, which is often worsened with positive pressure ventilation. The final thing that you can do is by improving the alveolar blood interface. How do you do that? Well, you get rid of all the gunk that's sitting in the alveoli by using chest physio, suctioning regularly to get rid of any of the sputum that's there, and also, most importantly, getting their total body water levels down. If you've ever seen an intensive care patient on the unit for, say, 2 or 3 or 4 days, you see that they start to become very edematous. Their skin becomes very boggy. Now, exactly like what's happening in the skin happens in the lungs. The lungs become heavy, sodden, and wet, like a sponge. And so by getting rid of that water, you're automatically starting to reduce the blood alveolar interface space, and therefore you're improving the efficiency of oxygen moving from the alveolar gas area into the capillaries to be oxygenated. I'd really love it if you just take a picture of this slide, or take just a second to really take this all on board, because this slide summarizes the only interventions that you can do as a doctor with a patient on a ventilator to improve their oxygenation. It is just these 4 points. That's it. So you'll start to see that actually ventilation is really quite simple, because as long as you improve these things, there's nothing else you can really do. And if you've optimized every one of these 4 points, then you need to think about another option. And that other option may be something like ECMO, which is extracorporeal membrane oxygenation, where basically you take the blood out, you oxygenate it in a machine outside of the body, and then put it back into the body. You will see lots of talks on that later on this channel. So, increasing the oxygen is the easiest thing, and you often see us just dialing up the oxygen to 100% if a patient is hypoxic or if they've had a cardiac arrest. The other more clever way of trying to increase the oxygen levels is by using a hyperbaric oxygen chamber. And this is a bit nuanced. We don't really use it in day-to-day practice. And when we talk about infections, I'll talk a little bit about hyperbaric oxygen chambers for things like necrotizing fasciitis. But for the most part, the only thing that you will have control over is the fractional inspired oxygen concentration, i.e. turning that dial up to 50, 60, 70, 100% oxygen. Now, ventilation is all about keeping the alveolus open. And so this is where PEEP comes in. Again, positive end expiratory pressure, the continuous pressure that goes into the lungs. And the best way to think about that is if you're driving down the car, you stick your head out the window and you just feel a rush of air coming in. It just expands out your lungs. That's what PEEP is. That's all it does. Now, you can also try and improve the alveolus being open by sitting the patient up. What does that do? Well, if you imagine a patient lying flat, you've got the whole weight of the heart and of the chest wall pushing down on the lungs, and therefore they're going to collapse down. Similarly, if you imagine the abdominal contents, it's going to sink down and push that diaphragm up, and therefore collapse the bases. So simply by sitting the patient up, you're getting rid of that weight that's on the lungs, which are basically just sponges, and therefore allowing them to expand out a little bit more. And the more alveoli that stay open for longer, the better your oxygenation will be. The clever ventilation bit I'll talk a little bit about in later presentations. We're talking about things like inverse ratio ventilation, high PEEP strategies, APRV. Again, I will talk about that later, but the important thing is to understand the fundamentals in this particular talk. Now, very occasionally, you might need to open the abdomen. Some patients may have a very tense ascites, and that's pushing up on the diaphragm, pushing the lungs, causing them to collapse. And simply by opening the abdomen, releasing the pressure, or by draining that fluid, what you can do is dramatically reduce the pressure of the diaphragm up onto the bases of the lungs, and therefore allow those bases to start expanding up. And again, the more alveoli that are open for longer, the more oxygenation you're going to get. I really want to reiterate the alveolar blood flow, because I think this is something people don't think enough about. You must think about shunting. Say, for example, you've got the whole of the left side of the lung that's collapsed. There's no gas getting into it at all. What you want to try and do is improve the amount of blood going into the right lung, which is the only lung that's expanded. So a really simple thing that you can do is turn the patient onto their right-hand side, i.e. their good lung is on the bottom. Blood is stupid. It's going to take the path of least resistance. So instead of fighting against gravity and trying to go up into the left lung, which has no aeration in it at all stays down in the bottom and the right lung, which is the one that's being oxygenated and ventilated, and therefore you can dramatically improve their oxygen levels, and also you can dramatically improve their carbon dioxide removal. So really worth thinking about the shunting and how you can optimize a patient's positioning to try and get that. Optimizing cardiac output is really important, and think about the patient's fluid status. Have you driven them too dry? Can we give them something to help their cardiac output, like an inotrope? Do we have enough of a pressure head to overcome the increased intrathoracic pressure that you've got now that you've got them on a high PEEP to try and keep those alveoli open? Nitric oxide is the medication that I said that you can entrain through the gas that can help vasodilate the areas of the lung that are being aerated. Now, the most important thing on a day-to-day basis when you're looking at your patient and trying to improve them, trying to get them off the ventilator, is thinking about the alveolar blood interface. Everything else that we're talking about up at the top is just a way of temporizing matters till the underlying pathology gets better. In a pneumonia, the underlying pathology is inflammation, infection, and pus sitting in the lung, causing collapse, causing consolidation. So, the first thing you want to do is to suction it out. So, good chest physio is vital in every intensive care patient. And then the second thing, the only other thing you can really do, is to try and get rid of that wall edema in both the alveolus and in the capillary wall, to try and reduce the thickness of the blood alveolar interface. So this is where driving a patient gently negative every single day, don't let them get away from you and having massively positive fluid balances every day, because all that water goes somewhere, and where it goes is into all of the organs in the patient's body, including the lungs. So always aim for a negative fluid balance if you can. Obviously, if the patient is ragingly septic and is very fluid responsive and needs that additional intravascular volume, of course give them fluid, but for the most part you should be trying to keep that to a bare minimum. There is very good evidence that if you give too much fluid to patients who are critically unwell, they do very badly. So again, I just want you to take a little bit of time to look at this slide. If you have a patient who is hypoxic on the ventilator, these are the only strategies that you can do to improve the oxygenation of that patient. So we talked a little bit about oxygen, but the other thing that's really important to think about is carbon dioxide levels. Because oxygenation is only one half of ventilation. The other part of ventilation is to remove the carbon dioxide that the patient is producing every single second from all of their cells that are metabolizing. So the question comes, what does carbon dioxide depend upon? Now, we said there were 4 things that oxygenation depends upon. There's only really 2 things that carbon dioxide depends upon. And those 2 things, when thinking just about the lungs, is the minute ventilation, i.e. the amount of gas that's coming out every minute from the patient into the ventilator, and the perfusion of the lungs. There's no point in lots of gas coming in and out if none of the blood is getting to those areas of lung that are being aerated or ventilated, because you need the deoxygenated blood with the high carbon dioxide levels to actually get to the ventilated bits of lung, which then allow the carbon dioxide to diffuse through the concentration gradient from the capillary into the alveolus and then out into the endotracheal tube and the ventilator. So minute ventilation and alveolar perfusion. So I said that minute ventilation is the amount of gas that comes out every minute from the patient and into the ventilator. So the only two things that you can change to try and improve the minute ventilation of a patient is increasing the tidal volumes, i.e. how much breath comes in and out of the patient every time the ventilator goes, and the respiratory rate, how quickly those breaths are given. So if you give 500 breaths per minute, if you give 500 mils of gas and you do 10 breaths per minute, then every minute you are making 5 litres of gas coming out of that patient's mouth, and therefore 5 litres of carbon dioxide rich gas coming out. If you make it only 300 mils per breath, the tidal volume, and do that at 10 breaths per minute, you are now only getting 3 litres per minute. So you can see there's 2 litres per minute reduction in minute ventilation just by reducing the tidal volume and keeping the respiratory rate the same. So you might say, well, if that's the case, if I've got a high CO2, why don't I just make the tidal volumes a litre or 2 litres each? What you could do, but then we come into a problem called volutrauma. If you imagine a balloon, if you blow it up way too much, it'll just explode. And the same can happen with alveoli, so you can get pneumothoraces if you blow up the lungs way too much. But actually more subtle than that is if you use large tidal volumes, you can cause micro tears in the walls of the alveoli, which then cause further inflammation and therefore further reduce the ability of the lung alveolar interface to diffuse oxygen and carbon dioxide. So it might work for in the short term, but in the longer term, it can cause what we call volutrauma. And the problem with volutrauma is that it can cause chronic lung disease, especially in those patients with severe respiratory illnesses and what we call ARDS, or adult respiratory distress syndrome, or acute respiratory distress syndrome, depending upon the literature you read. Well, then you might say, well, why don't we just increase up the respiratory rate as much as you want? We can have a respiratory rate of 35, 50 breaths per minute and keep the tidal volume low. Well, you could do that. However, the problem with that is you can then get into problems with the amount of time that you allow to release the gas and the amount of pressure that you need to be able to generate a breath of, say, 300 mils in a very short time period. And we'll go through that in a lot more detail in the next set of talks. But for this particular presentation, what I want you to take away is that CO2 is dependent on the minute ventilation, and the minute ventilation is dependent on the tidal volume and the respiratory rate. So, if you need to increase the carbon dioxide excretion, you need to either adjust the tidal volume or their respiratory rate. Now, some of you who know a little bit more about advanced ventilation know that that is slightly more nuanced. And when we think about things like high frequency oscillation or APRV, carbon dioxide removal is a little bit more complicated than just your minute ventilation. But for the purposes of basic ventilation, just think of your tidal volume and your respiratory rate. And then the second thing that everyone always forgets is optimizing cardiac output. You must make sure that even if you've got the greatest ventilation strategy on earth, if you don't have enough blood perfusing the lungs, all of that blood is just shunting straight back into the left side of the heart and not allowing carbon dioxide removal. So always make sure you've optimized the right side of the heart with fluids, with vasopressors, and with inotropes as appropriate, and get help with that. That is not an easy thing to do, and even the most experienced consultants still struggle to try and optimize alveolar perfusion. But don't forget about it. So that's really the important parts of this talk. And what I've gone through is how to oxygenate a patient and how to remove CO2. Those are the bits that you really need to consider for the next couple of talks that we'll talk about. And we'll go through ventilation and different modes of ventilation, but it all boils down to these simple things. To improve oxygenation, the only things that you can do is increase the FiO2, keep the alveoli open for as long as possible, and then improve their perfusion as best as possible by improving the right side of the heart, and then improve that alveolar to capillary interface by drying the patient out and suctioning them. The only thing that you can do to improve the carbon dioxide levels is by increasing their minute ventilation, which is a function of their tidal volume and respiratory rate. And finally, alveolar perfusion, as we talked about with oxygenation, is really important and something that is always worth bearing in mind. I really hope that's useful, and if you did find the video useful, please like and subscribe and hit the bell notification. There's going to be quite a lot of videos coming out over the next few weeks looking at ventilation, going through everything from the very basics through to the most advanced modes of ventilation like APRV, and then moving on to things like ECMO and the management of that. So thank you very much, and I will see you next time.